it has become very clear that conventional beam-mode ultrasonography is very widely used as first liver imaging approach for any condition. Let's say for the patient says, I want to make some general assessment to having a raise in liver enzymes. Hence, most focal liver lesions are first detected by conventional ultrasound. However, as you can see from here, the capability of conventional ultrasound to accurately establish the nature of focal liver lesion is rather limited. You can see here that we have hyperechoic lesion here, but they are of different nature. But most of these were confirmed by histology and pathology. So conventional ultrasound may be able to assess, to achieve the diagnosis all itself without contrast imaging, probably no more than 50% of the cases. So we are looking for a strategy to establish whether a lesion is benign, as it was shown by Christoph Dietrich, or whether it is malignant. The pathway to malignancy, the carcinogenesis, was defined in 6 main, let's say, pathways. Some are permissive, some are genomic instability, and there has been a 7th one described recently, which is the inflammatory environment. But of all these ones, there is one, which is the angiogenesis, which might be detectable from, let's say, outside. For all the others, we need some piece of tissue. I've shown you before that when we put cells in vitro, they stop after a while increasing, whereas when we implant them in tissue, they might be able to grow indefinitely due to the development of new vessels. These new vessels are not only new, they are different from normal vessels. This is the main point, because if it was only a point of number, probably we would not be able to make diagnosis. So it's not just a matter of numbers, it's a matter of the morphology of these vessels, which are different from the normal vessels, normal arterial vessels. They are irregular and tortuous. There is no progressive decrease in calibers, and they lose the smooth muscle wall layer, and they lose the endothelium in the liver, which leads to an alteration of perfusion times and to abnormal flow. So the key point is that by contrast imaging, we are able to assess the vascularization of the lesion. The second point is that we should not think of ourselves as people, as physicians looking at images only, because these would probably cause to have very many false diagnoses, but we should be physicians. We should visit the patient, we should take the patient history, and in this setting it is particularly important because the diagnosis is not made on a tissue. We don't give the exact diagnosis. We made an estimate of probability, which often is nearly to 100%, so it's like making a diagnosis. But to make an estimate of probability, we should put together not only the imaging pattern, but also the clinical setting. So the first question for an appropriate Ceus characterization of focal liver lesions is the patient affected by cirrhotic chronic liver disease? And this can be derived from clinical and laboratory data. So I strongly recommend never to put the patient on the bed without having the charts in your hands before, or having the possibility to look at them, and directly by imaging. So before going and looking how the pattern of the lesion is, always take a look at the whole liver if the history is not enough to tell you what has the patient, if he has chronic liver disease which has progressed to cirrhosis or not. So you cannot say, oh, I'm sorry, I was not aware whether he was cirrhotic or not, because you have the tool in your hand to know to answer this question. So if the patient is cirrhotic, we should fall in the chapter of differential diagnosis of focal liver lesions in cirrhotic liver. If the patient has not cirrhosis, then it is a completely different chapter, that the differential diagnosis of focal liver lesion in what we call healthy liver, which might not be completely healthy, it might be fatty liver, but healthy in this setting means without cirrhosis. So we will talk about malignant lesions, which in the case of a healthy liver means most often metastasis or might represent cholangiocarcinoma, rarely hepatocellular carcinoma, hemangiopericytoma, and other rare malignant lesions. So this is more than 90% of the cases. This is about 5–6%, and the remaining are just a few. If you move to the cirrhotic liver, then hepatocellular carcinoma represents more than 95% of malignancy. So you understand that just without looking at the lesions, but just knowing whether the patient is cirrhotic or not, we have a high probability of making the right diagnosis. So this clearly points out how it is important. So let's move to the healthy liver and its malignant pattern of lesions. I think this is clear. We might have different appearances of the lesions at contrast-enhanced ultrasound in the arterial phase, but all these lesions wash out, which is the term that we use to say that the lesion becomes dark, and this might be a markedly hypoic lesion up to anechoic, echo-free, or might be only slightly or moderate. Usually it tends, the malignant lesion in healthy livers tend to become very dark. As you can see, as you have just seen in the previous talk on benign lesions, the arterial pattern itself does not make a diagnosis of malignancy, because this is a pattern that can be found also in focal nodal hyperplasia or adenoma. We might find small hemangiomas which are isoechoic. The only pattern that maybe has a certain strength in suspecting a malignancy is the rim enhancement. However, by itself cannot make a diagnosis, because an abscess also might have a rim arterial enhancement, which is due to the inflammatory hyperemic area around the infection. So none of these features by itself make a diagnosis of malignancy, whereas when the lesions, which has some contrast enhancement in the arterial or portal phase, becomes dark, it washes out, then this is the key feature to make a diagnosis of malignancy. So wash out. But to wash out, the lesion should not be always dark. It should be enhancing and then becoming dark. This is an old case, but it was one of our first cases that showed us how different it was, contrast-enhanced ultrasound, from any other previous technique. You see that there are two slightly hypoechoic lesions. In the arterial phase, one is homogeneously enhancing, the other has a rim enhancement. This is the late arterial phase. Then in the portal phase, you miss them, because there is the transition from hyperechoic to hypo, so it means that it passes through a period of isoechogenicity, and then they become dark. If you put in mind these images, if you put them in your minds, then you know forever how a malignant lesions appear in a healthy liver. As early as 1999, this early publication with the first generation contrast agents and first high mechanical index technique could show what is more or less remain the same. When you use contrast and ultrasound and you compared it with the sensitivity in detecting malignant lesions of ultrasonography, you have in more than 50% of the patients the possibility to detect more lesions. In a certain number of patients, you detect the same number of lesions, and in a few cases, you detect less lesions with contrast and ultrasound than with conventional ultrasound. You may wonder why. How can it be less sensitive? The problem might be, especially with the first equipments, that if you don't set your equipment perfectly and the lesion is very deep, when you have a lot of contrast, it blocks the ultrasound waves. They are not able to go very deep. And so something that might be visible with ultrasonography might not be visible anymore with contrast-enhanced ultrasonography, because you have not set your equipment in the right way to penetrate deep enough. This is the reason why there are some cases that might be seen with ultrasonography and not by Ceus. But if you set your equipment perfectly, then this number should tend to be 0. And then these figures subsequently confirm that Ceus is able to see some lesions that are missed by helical CT. This is another manuscript of the same period which confirmed this data. And we have also had a similar experience. These manuscripts were all a little bit old when we think at contrast at CT examinations. So now we have more performant CT scanners, but also better ultrasound scanners. And also in this case, we could show that this is, I think that the point of this manuscript is that we try to focus not on any cancer, because in some instances there is no role for detecting more metastases. If a patient has a lung cancer and has 4 in 5 or 2 metastases, it doesn't change at all the approach. So it's not worthwhile to proceed to perform Ceus. But when we talk about gastrointestinal cancer, and these were nearly 90% patients with colorectal cancer, then it makes a big difference if the patient has 2 or 8 metastases, because in one case he might be operated, in the other he is not anymore a surgical candidate. So we try to focus on a population in which the change in the staging and the number of lesions might really change the therapeutical approach. So these were consecutive patients. You see that in about half of the cases there were concordance of no lesion. In another high number of occasions there were concordance in the number of lesions. Patients with more than 4 metastases detectable at ultrasonography were discarded because there were already too many. But there were a number of cases in which a metastasis could be detected either by contrast and ultrasound or by CT. So the conclusion is that if you want to make the best assessment on the number of lesions before sending the patient to surgery, then probably the best solution is to use a couple of techniques, contrast and ultrasound plus CT or plus MRI. These are various cases showing the advantage of Ceus. This is a patient operated for cancer in autumn 2003, and he had at that time 2 small hemangiomas. He was a patient with cardiac disease, atrial fibrillation, so he was anticoagulated. In the subsequent year, he gained weight and underwent chemotherapy. This often determines the development of a fatty liver. And then when he came back, there were still these 2 hyperechoic lesions, but also these hypoechoic lesions near to the portal bifurcation. This is a typical site for fatty sparing. So in this case, it is more difficult to decide stop warfarin and go to biopsy. And so it's important when a patient has a fatty liver to proceed to better techniques, and Ceus for sure is one of the best. And you can see that this area, which could be theoretical a focal fatty sparing, as instead a Riemann enhancement, and when you go to the late phase, it washes out. So this is sparing, it was biopsy and confirmed to be a metastasis. And during the follow-up, you understand that Ceus, being so safe, less expensive, is better than radiation techniques if the liver can be explored in a good way. This is another case, a young lady operated for breast cancer 5 years before. She was submitted to chemotherapy, responded at first, but then there was an increase during second-line chemotherapy in tumor plasma marker. He came for ultrasonography, and we thought that this was the reason for the increase of the plasma marker. This was the usual standard. It was 6 years ago, conventional ultrasonography, but by Ceus there was no washout in this area, but there was a washout here. And there was a little bit unexpected, but then she was submitted to PET-CT, and PET-CT indeed confirmed that the lesion was there, where Ceus saw the lesion and not where conventional ultrasound had seen the lesion. This is another recent case. This was about 3 months ago. A patient operated for breast cancer 3 years before. She was detected with these focal liver lesions that we usually classify as focal fatty sparing. It is near to the gallbladder, and in this case we could stop. But She is a cancer patient. So this is a clip. In a cancer patient, it might be more difficult to say that this is a focal fatty sparing. So we prefer to confirm it by Ceus. And when we go with Ceus, the plasma markers were a little bit raised, so there was this suspicion. Arterial phase, 31 seconds. There is no arterial enhancement. Okay, this is confirmed to be a focal fatty sparing. Good. But then it appears here that it is something different. You see that it is washout. And this is where the metastasis is. And probably the focal fatty sparing might be as a consequence of being nearby to the lesions because of arterial venous shunt. This is a possibility. But actually, if we had biopsied this lesion and not this other, we would not have get the right answer. So the patient was biopsied here, and it confirmed that it was metastasis. And you know that by now it is very important to have the assessment of the receptors to make appropriate chemotherapy. So Ceus in this setting is very important. So you have learned how metastasis in healthy liver appears. If we go now to cholangiocellular carcinoma, there is no specific appearance. So it looks like a metastasis. It might enhance in the arterial phase, it often does, and it wash out in the late phase. There is no specific key feature at contrast and ultrasound to make the diagnosis. But there are some news in the literature because the Ceus pattern may differ from that of MRI or CT. Because at MRI, late enhancement of the lesion, in case of cholangiocellular carcinoma, may take place, as contrast agents, especially gadolinium-based, tend to link to fibrous tissue, of which cholangiocellular carcinoma is occasionally rich. So there is not the expected washout with MRI. This has been reported by many articles, whereas with Ceus, and especially with Sonoview, which is a pure blood pool agent, this does not take place, and hence you have the typical pattern of malignancy. So the recommendation is that if you have a large liver lesion detected at ultrasound and devoid of late washout at gadolinium MRI, this patient should undergo Ceus, if not showing the typical hemangioma pattern at an enhanced MRI. So you see the lesion. If the patient goes to MRI, even if at MRI does not have a washout, but it does not have the typical hemangioma pattern, the second step should not be CT, because CT behaves a little bit like MRI, but Ceus. Because with Ceus, you have the typical appearance of malignancy. This is a case that we have seen just a week ago. 63 years lady, never submitted to ultrasound scan of the liver, occasional detection of 2 hyperechoic lesion, this one, which seems to be in hemangioma, and this more atypical. This is the CT she brought with her that said that this lesion did not have washout. It did fill in because this appears less echoic, less intense than in this phase. And there was a suspicion of hemangioma, but I don't know why the radiologist recommended MRI. She attempted it, but due to claustrophobia, she could not stay in the machine, and so it was not performed. And she came then for Ceus, enhancement in the arterial phase, then start to wash out in the portal phase, and washes out in the late phase. So we could not confirm hemangioma, and this patient will be submitted to biopsy because of this discrepancy. And in my personal opinion, we will see, but there is a high suspicion of cholangiocellular carcinoma. This is peripheral cholangiocellular carcinoma. If you have material at within the bile ducts, occasionally you might have a suspicion that this is there is some stenosis obstruction downstream. This is only, let's say, dense bile. And by contrast and ultrasound, if you want, you can confirm that this is tissue because it's perfused in the arterial phase and washes out. So it behaves like the peripheral cholangiocellular carcinoma, and this is cholangiocellular carcinoma of the common bile ducts. These are the most common patterns. Then we have situations where you have to take a little bit care. This is a large lesion in a 75-year-old man, enhancing in the arterial phase. The Ceus pattern is similar to that of CT, enhancing in the arterial phase and no washout. Also at Ceus, no washout, so no cholangiocellular carcinoma. MRI the same. Should this be judged as a benign lesion? No. Why? The clinical setting is not for a benign lesion. This was known to be there a few months before. It was a little bit smaller, but this is elder male. It might be benign, but it's not very likely. So we cannot stop here. We should proceed to biopsy, which indeed confirmed hepatocellular carcinoma. And we will see why it was an hepatocellular carcinoma. So we skip now to the other setting. These were the pattern in healthy liver. Washout is the key feature. The late phase is the key feature. Hepatocellular carcinoma probably is the most tricky situation, but we will expand this now. Now we are discussing of lesions developing in the liver cirrhosis. We know that patients with liver cirrhosis are scanned with periodically with ultrasonography, and we might detect lesions. But unfortunately, ultrasound is not able, also in this case, and specifically in this case, to tell us whether the lesion is benign or malignant. You see that these lesions, very similar to each other, one is a regenerative nodule, and the other is a cancer. And the same for this. This is a cancer, and this is a regenerative nodule. So how can we distinguish them, and how often we do encounter these sorts of lesions? These are studies of surveillance of cirrhotic patients in 3 different centers, Milan, Barcelona, and 2 from Bologna. And you see that considering all lesions occurring in cirrhotics, we demonstrated about 80% were finally cancer. If we stick to lesions, small lesions, 1 to 3 centimeters, in a second study, we confirmed more or less the same percentage of cancers. The other were benign lesions, mainly hepatocellular lesions, regenerative nodules or dysplastics. If you go to smaller lesions, less than 2 centimeters, then about you see 67% or 66% were hepatocellular cancer. A few were cholangiocellular carcinoma, 1 in this case and 2 in these cases, and the other were hepatocellular benign lesions. So altogether, to summarize, which nature is expected to have a focal liver lesions newly detected in a cirrhotic liver? From a likelihood approach, if it is between 1 and 2 centimeters, 75% are HCC, hepatocellular carcinoma. If the lesion is between 2 and 3 centimeters, then you raise to 85%. And if it is more than 3 centimeters, then it is 90–95%. So when you see a lesion, you should start from the point that this is a cancer. I have to demonstrate otherwise that this is not a cancer. I have to be certain. And finally, if it is not an HCC, it might be most likely a regenerative dysplastic nodule, less likely hemangioma, and less likely even more cholangiocellular carcinoma or lymphoma. This figure shows how it is relevant, the perfusion. You see that from regenerative nodules, low-grade dysplasia, high-grade dysplasia, early hepatocellular carcinoma, well-differentiated hepatocellular carcinoma, and classical frank cancer, there is a decrease in the normal arterial supply, then a start of the angiogenesis from the early cancer, which takes over the whole blood supply in frank cancer. At the same time, you have a decrease in portal supply. If you can keep in mind this figure, you know everything about liver nodules. So how can we make the diagnosis? The key feature are the detection of the neo-arterial angiogenesis, which, however, can be detected only when it overcomes the arterial flow of the normal parenchyma, which is only in frank cancer. And so we have certain lesions which might be still benign or already cancer, which we call hypovascular, or this is not truly hypo because some of them are not less vessels, is that they don't have yet the enhancement more than the surrounding parenchyma, and therefore are called hypovascular, but this is not perfect definition. And at the same time, they lose the portal perfusion, but since during the portal time you mix together the arterial perfusion and the portal perfusion, you are able to detect that there is a washout only in the late phases with Ceus, not in the early loss of portal supply. So it is clear that we have to look for arterial enhancement together with washout to make a diagnosis. And this is how the lesion, how it should happen. Hyperenhancement in the arterial phase and then transition to hyperenhancement, which, however, is only moderately hypo. You nearly never see that dark appearance in the late phase. We don't know why exactly, but this is only moderate hyperenhancement. I can show it. Which I can show in this other case. This as a patient already treated for cancer. He has a new lesion here. This is subcostal scan. This is the intercostal scan, barely detectable lesion. 16 seconds starts the hyperenhancement. 18 seconds clear hyperenhancement. And in the late phase, it washes out. You see that the washout is very faint. And the second point is that for hepatocellular cancer, you have to wait more than 3 minutes. So the washout takes place, but it takes place slowly, and usually with metastasis, they are dark already 2 minutes. For liver cancer, you have to wait 3 or 4 minutes to assess whether there is washout or not. This is another case which shows over time how the neoangiogenesis increases while the cancer develops and increases in size. This is May 2005, only tiny hyperenhancement, but due to this appearance, the patient was put on a waiting list for liver transplantation. This is a few months later. You see how the neoangiogenesis has flourished. The patient was finally transplanted. So to conclude, how should we manage the diagnosis of malignancy and cancer in cirrhosis? When we see a nodule, if this is less than 1 centimeter, then we do not need, according to the guidelines, yet to use contrast enhanced techniques. It could be followed with ultrasonography at interval from 3 to 6 months. I would strongly recommend 3 months and not 6 months, because the earlier we make a diagnosis, the higher the probability we might be able to ablate it completely, or we might submit this patient to transplantation. If the nodule instead is between 1 and 2 centimeters, these guidelines are still valid. They will probably be updated in the next months. They will appear in the AASLD website at first, and then they will be published in Hepatology. Then the nodule should be investigated with 2 dynamic techniques at least, which include CT scan, contrast-enhanced ultrasound, or MRI. If there is at least of 2 of these methods, the typical pattern, hypervascular plus washout, then we have the diagnosis. We don't need the biopsy. But since in these small nodules there is a higher risk of, let's say, false positive, especially with CT, of having a fistula, especially if you are not sure that there is washout. Washout was asked to be there in the criteria in order to avoid that transient hyperattenuating defects or fistula could be misdiagnosed for cancer. So you have to have washout, and you have two concurrent techniques, then you make a diagnosis of cancer. This is to show that for the detection of washout, Ceus is less sensitive than CT or MRI. You see about 10% less in this study from Barcelona, 10% less in our study, and in this study you see that of all liver cancer, about 90% show the typical pattern in the arterial phase, but only about 42%, similar to 52 and 42, showed the washout. So you see that unfortunately Ceus, probably because of this, of being a pure vascular agent, so it does not exit the capillaries in the liver, which might contribute to detect the washout. The sensitivity for washout is not very high. So there are a number of cases which cannot be diagnosed with contrast and other techniques. What should we do with the nodules which do not have the typical profile? They should be biopsied. If the findings are not characteristics of the vascular profile is not coincidental among techniques, the lesion should be biopsied. Either whether it is between 1 and 2 centimeters or more than 2 centimeters. So we have a lesion here. No arterial enhancement, no washout, and needle is put inside it. This is a truly hypovascular nodule, dark in the arterial phase, and then isoechoic. This should be biopsied. We did not biopsy it because it was non-lady, not well cooperating, and it is very close to the heart. You can see here the right heart. And from a hypovascular lesion, which could be cancer or not cancer, in a few months, it became hypervascular. And this clearly shows how it tended to progress to frank cancer. So what is important that the biopsy is negative, that it is not 100% not cancer. If the lesion changes in size or perfusion over the next months, biopsy should be repeated because there is a risk of false negative cases. So I hope that the message for the diagnosis of cancer in liver cirrhosis was clear. This applies also to portal thrombosis. If a portal thrombosis has arterial enhancement, then it is malignant portal thrombosis. I don't go in further details. I want to stress, just to conclude, that the persistently isoechoic pattern is not specific for hemangioma or for benign lesions. It might also be a hypovascular cancer. Metastases are very rare because they are difficult to be distinguished from hepatocellular carcinoma, but fortunately they are very, very, very rare in cirrhotic for reasons mainly unknown. And finally, we should know that cholangiocarcinoma and lymphoma might occur 2–3% of the cases. And from the Ceus point of view, they are not distinguishable from HCC. A key feature which might suggest that this is not hepatocellular cancer is a discrepancy between the appearance at MRI and at Ceus, as I've discussed before. Okay, so how should we do? Clinical setting. Asymptomatic, no suspicion of malignancy. Typical hemangioma, yes, stop, okay. If not, proceed with Ceus, because probably this is a benign lesion, and as Christoph Dietrich pointed out, maybe it's not correct to give radiation to these patients. If it is instead at Ceus, so these techniques likely malignant, should perform other techniques and go to biopsy. If there is cirrhosis, 1 or 2 lesions, then we should perform Ceus or CT MRI. I will discuss this in the next talk. And if there are more lesions, then probably Ceus is not the good technique because it's not panoramic, and we should go directly to CT or MRI. If the setting is oncologic, then we should consider more panoramic techniques. I thank you for your attention.